Thank you very much, and good morning, everybody. So I've been asked to talk to you about improving critical care and outcomes using National Clinical Audit. And I suppose the first thing I'd like to say is thank you for inviting me. San Diego, a lovely city. And particularly the theme of this conference, the continuum of care, is one that's very close to my heart. And I look forward to spending the next couple of days learning a lot in the various sessions. I think as a Brit, it's also rather nice to leave Brexit behind for a little while. It certainly dominated our media and our politics over the last couple of years, so it's nice to take a break. So National Clinical Audit. So what are our expectations of National Clinical Audit? And I suppose the first thing I would want to say to you is I think we can pose two questions of it. First of all, can we know if the performance of critical care in a nation, a region, a network, a state is good? And if it's getting better or worse over time? And the sort of second question I would pose of National Clinical Audit is, can a meaningful and reasonably understandable set of national quality indicators be identified, be accepted by key constituencies, and then tracked in ways that allow system-level performance not only to have a greater prominence, but to become part of evidence-based policy discussions and decisions about critical care? So what I'm going to do over the next short period of time, I hope, is share our experiences of National Clinical Audit in the UK and provide you some reflections that I hope will be useful and thought-provoking in terms of activities in the US and elsewhere. So first of all, I think a bit of context. I work within the National Health Service in the UK. It's an integrated healthcare system, integrating primary, secondary, and tertiary care. We have about 250 acute hospitals in the UK, and about 20% of those are what you might call university or academic medical centres, with the other 80% being non-university or smaller district general hospitals. And then the other thing about our healthcare system is it has a single payer, it's paid for via taxation, and free at the point of use. When it comes to sort of drilling down into adult critical care in the National Health Service, we deliver our critical care predominantly in what we would call combined units, the units that are trying to provide across the whole sort of continuum of care or continuum of critical illness, high dependency, intensive care, high dependency care. And we also deliver it in what we consider to be general units, so rather than having separate medical and separate surgical units, we have combined adult general critical care units. And these are very much closed units that are intensivist-led, so the patient moves into the care of the intensive care team as they move into the unit. We do have some large units, we call large, sort of 50 to 60 beds, but the median size, I think because a lot of the units are based in these smaller district general hospitals, is only about 12 critical care beds. And on average, about 20 to 25% of patients admitted to critical care in the UK don't survive to ultimate discharge from hospital. So how did I get into this game? Well, in the mid-80s, I was actually doing epidemiology in malaria in West Africa, learning my trade, and realizing that I wanted to come back and actually get a qualification. And I returned, and I got a job at the University of Oxford to coordinate the UK Apache 2 study. And I found myself catapulted into the world that you guys all populate, delivering critical care and measuring outcomes of that critical care. And so over a sort of 5-year period in 26 intensive care units, I did a study essentially assessing the Apache 2 model and calibrating it for the UK. At the same time as I was doing my PhD, actually national policy in the NHS was actually beginning to engage with something that they initially called medical audit, and very, very quickly realized that, certainly in the area of critical care, but most of healthcare, that care is delivered by a team of doctors, nurses, other allied health professionals, it soon became clinical audit. And probably most importantly, in 1997, in the white paper called The New NHS, Modern and Dependable, they actually made chief executives of hospitals not only responsible for the corporate governance of their hospital, but also for the clinical governance, that they had to be able to assure themselves that high-quality care was being delivered within their hospital. So those two sort of situations, me doing the Apache 2 study, the national policy of audit sort of being driven into the NHS, led me and the academics I was working with and the clinicians, the professionals I was working with, to put a proposal to our government to basically establish a national clinical audit in critical care. In 94-5, we got a pump priming grant with a remit to be self-financing. We set it up as an independent, scientific, not-for-profit, and one of the things that I drilled in straight away was to have patience amongst the trustees of our not-for-profit organization. And our aim was to foster improvements in the organization, practice, outcomes, and experiences of critical care for patients and for those who care for them. With the A, or the audit, being about assessing quality, and the R, the research, being about establishing quality. So our national clinical audit, we actually run two. We have one on in-hospital cardiac arrest, which we run with the Resuscitation Council UK. But the one I'm going to talk about today is our one on adult critical care, the Case Mix program. It's subscription-based, so each critical care unit participating pays ICNARC $6,000 or thereabouts per year to take part. And the idea of it is this central local partnership that's about improving critical care. And it's established through a high-quality clinical database. So the first thing we set about doing was actually agreeing a standard dataset specification for consecutive admissions to critical care. This included definitions for variables, rules for data collection and capture, and also a full IT specification, as well as a kind of defined export schema. And I think one of the key things we had to bear in mind was when you're going to do national clinical audit, you've got to have a system that allows the least well-resourced units to participate, as well as the most well-resourced. Our data set, if you like, captures that continuum from original admission to hospital to ultimate discharge from hospital. It captures the critical care stay, the red line as part of the continuum that you can see on the slide. And you can see that the bulk of the data is for risk prediction modeling in the first 24 hours in the unit, with then data on acquired infections, organ support. And we follow patients to survival from hospital, destination following discharge from hospital. Most importantly, from about sort of 2005-06 onwards, we started to capture a newly introduced unique identifier that had been introduced into the NHS, the NHS number. And this actually allowed us to have a unique identifier for data linkage downstream. So how does it work? Well, we collect data on a quarterly basis. That's much more to do with sample size than anything else. So one's trying to capture a set of admissions that one can do a reasonable set of analyses on. So units collect data or capture data depending on their resources for each consecutive admission for a quarter. They upload that submission to ICNARC. It goes through very, very thorough data validation. And then we provide an online report back to the unit. It was voluntary, which was quite an interesting thing for me. We had to win our customers. Rather than being mandated, we actually were delivering a service. And as you can see from this graph here, over time we won our customers. And I'm pleased to say that now we have 100% coverage for England, Wales, and Northern Ireland, which we have the scope and remit for. We do run the audit also in Ireland with the authorities in Ireland. And Scotland has its own independent audit, but we link with them. So we've now got 290 critical care units. And you can see how they break down along the bottom there. And we have a very small non-NHS or private sector, but you can see there that we now are starting to also be able to audit the care and outcomes of the critical care that's provided outside the NHS. So what are our outputs? Well, our current set of what we call potential quality indicators are these ones. And what you can see here is they are actually about that continuum of care. The first two are actually trying to capture patients who are admitted to our intensive care units, what you might call too late or slightly too late, because we do know that if we don't get patients recognized out on the floor and transitioned into the critical care unit, outcomes are poorer for those patients who are admitted late or too late. We have a quality indicator around the acquisition of a unit-acquired infection in blood. We have out-of-hours discharges to the floor. These are patients who are prematurely discharged from the intensive care unit. And then the next three are about a new problem that's developing in critical care in the UK, which is one of sort of bed blocking, where we're unable to discharge our patients because there aren't hospital beds in the hospital. So we're capturing the amount of bed days of care that are provided to patients who are now fully ready to leave the intensive care unit. We have non-clinical transfers to another critical care unit. These are patients who don't get all their critical care in one unit due to pressures on the unit. Unplanned readmissions within 48 hours. And then our risk prediction models underpin our risk-adjusted hospital mortality. This is our co-designed report here. Just thought I would show you the page of it. Some people like graphically represented data. Some people like tabulated data. I like definitions being on a page of a report so nobody can misinterpret, and also trends over time. Just moving on, we prefer the funnel plot. The reason we prefer the funnel plot is it allows us to account for sample size along the x-axis there. You've got the numerical value for the quality indicator on the y-axis, and then you can see the 2 and 3 standard deviation lines for the funnel. So units outside of 3 standard deviations are identified as having an alarm, and units between 2 and 3 standard deviations in 2 consecutive quarters are seen as an alert. And you can see here that, co-designed by our clinical teams, they like to be able to see their own unit in the orange dot there. Similar units to them, we have an algorithm for identifying similar units, the navy blue, but also the full scatter of all units in the audit. And probably more for the more managerial side of things, our managers like RAG ratings, red, amber, green, so tabulated data and a sort of traffic light system so they can quickly interpret how the unit is doing. As well as our quarterly quality report, we provide mission numbers back for local quality improvement. So this is if you have a whole slew of unplanned readmissions, you can actually get those admission numbers and do local review, local quality improvement, root cause analyses of why those events occurred. We provide the derived data back, and we also, in association often with the commissioners, the providers of care, and the managers of care, will often do an investigation if a unit requests and invites us to do so, so additional analyses conducted free of charge. Something I never thought I'd see in my lifetime was actually in 2009 onwards, we now annually, once a year, with permission of the units, publicly report the results of our national clinical audit and provide the data so we have a very strong relationship with our commissioners to populate their dashboards. So if you have a favored UK hospital and you want to see how its intensive care unit is doing, you literally can go online and look at it for the 2017-18 on our online reports. And this is here, the sort of NHS England dashboard. So that's great, Kathy, but does it impact? Does it have any impact? So I just thought I would show you a few sort of statistics from some of our quality indicators. So this is us trying to reduce the sort of delayed admissions to critical care. I've chosen the high-risk sepsis admissions from the floor or the ward here. And you can see over time along the bottom there that they are reducing over time. And it's okay to look at an overall rate to see if things are moving in the right direction. But what you also, this is the funnel plot now for the same data, you also want to be sure that all units are sort of moving. And you can see the horizontal line at about 12% here with the 2 and 3 standard deviations for 2009-10. And I hope that you can see here that the bar, the horizontal line has dropped, and the units in orange, which are now the later data, are scattered sort of further down, so lower proportions of high-risk sepsis emissions from the ward. Unit-acquired infections in blood, it seems like we were making good progress, and in around about 2014-15, it seems to have plateaued a bit. But again, you can look at this across all units and see the improvement over time, with now a large number of units having 0 patient days for unit-acquired infections in blood. Out-of-hours discharges to the ward, so this is these premature discharges, outside office hours. And this one you can see has a general trend down, but it shows that seasonal variation. Every time between about December and January, we actually get that peak, because essentially that's when our units are most under pressure. But again, you can see from the funnel plot here that out-of-hour discharges to the ward, the scatter in 2009-10, and a slight improvement in terms of overtime. And finally, you can also share these sort of data with your commissioners and your policymakers. This is the increasing problem of the bed blocking in intensive care, such that we're now discharging patients from the critical care unit so well that they are going straight home and not bothering with a period of stay on the floor in the hospital. Quite an expensive way to deliver care. And again, you can see the back in 2009-10, and you can see the shift upwards in terms of discharges direct to home. In terms of risk adjustment, we're always using the best risk prediction model that we have at any point in time, and we've continued to improve them over time. And what we do with risk adjustment, as I'm sure you know, a risk model is supposed across the range of risk to predict mortality that actually mirrors observed mortality. And in this situation, as the units improve, they're getting better actual hospital survival relative to what we predict. We sort of recalibrate the model. So it's a little bit unfair on them in that they look like they're all doing well, and then we recalibrate and it recenters it around a mortality ratio of 1, where observed and expected hospital deaths are equal. But if you were to go back and look in 2000 at the model that we were using then and apply that over time, you can see this gradual improvement in risk-adjusted mortality, so a reduction in risk-adjusted mortality over time, suggesting that the sort of regular moving of the goalposts actually is hopefully nudging improvements in terms of risk-adjusted mortality over time. We've now got a database of 2.5 million admissions to critical care, which is a large database. And as it's grown over time, we've done a lot of work led by my statistical colleague at ICNARC, David Harrison, to actually improve risk prediction modeling. I think it's really important that if we're going to provide such statistics as observed and expected acute hospital mortality, that we're doing that using the best risk prediction models that we can actually develop. So in 2007, we took the best of Apache 2, 3, 4, SAPS 2, 3, the mortality probability models, and we collapsed that and we produced, we hope, a better model for the UK, the ICNARC model. And then more recently, we've taken an even greater step in sophistication, where we're now using multiple imputation for missing data. We're realizing that the relationship between physiology and mortality is not linear, but so we actually now model that non-linear relationship. We actually are aware of interactions between individual physiological parameters, and we've expanded our sort of model to actually fit for specialist ICUs and also for high dependency care, the lower range of risk. And again, that model, again, we feel it's important to publish these things so they have the credibility amongst our critical care colleagues. So quality indicators, there's no two ways about it. We call ours potential quality indicators for a reason. And that actually is because there is a shortage of what you might call ideal quality indicators, ones that are valid, reliable, and strongly linked to patient-centered outcomes. However, I don't think that should sort of challenge us actually doing this work. I just think we should always be alert to the fact that some of the indicators may not actually be measuring quality of care. The other thing that's important to be alert to is that indicators may change over time. And this is the work that we did way back in 2000 in the LANCET, where we became aware of this notion that patients were being prematurely discharged from intensive care at night. And what we showed was for patients who were discharged between the hours of 10 o'clock or 7 o'clock in the morning, actually they had increased odds of about 33%, case mix adjusted, not to survive to leave hospital alive. And that was even greater if you chose out of hours between midnight and 5 a.m. And in terms of sort of close links with commissioners and policymakers, I don't think it was coincidental that in the winter of 2001, after the paper was published in April 2000, that this contributed, I think, quite significantly to actually a serious investment in actually high dependency beds in our critical care units, trying to ameliorate this problem of premature discharge from intensive care. So we sort of expected, you do a piece of research, you show that something's not a good thing to do, the policymakers respond by increasing beds. We truly expected to see, this is the graph of discharges between 10 and 7 a.m. over time here, and the paper came out in 2000, and we expected to see a lovely drop-off, and we'd be able to tell everybody, we've done some research, it's had impact on practice, I could dine out on it, come to the Society for Critical Care Medicine and give talks. And then what we actually realized when we looked at this in detail was this is where we began to realize that actually this new problem was developing. So although the discharges between 10 and 7 a.m. were actually increasing over time, actually an increasing component of those were these patients who were fully ready to be discharged from intensive care, and actually discharging them to the floor between 10 p.m. and 7 a.m. wasn't actually a problem. It didn't confer an additional risk of death. It was actually only in those ones that were prematurely discharged, and in fact, those did slowly reduce over time. And in terms of our quality indicator, we then had to adjust what we were measuring, not just out-of-hours discharges to the ward, but actually, in parentheses, those ones that are not delayed, to make sure that we were still capturing the patients for whom that sort of discharge could in some way influence their likely outcome downstream. So one of the other things that I think about National Clinical Audit is the added value that it can actually deliver in terms of the fact that it's established through a high-quality clinical database. I just wanted to kind of run through some of the added values that I see from having this high-quality clinical database. The first is the opportunity to work with the best way. I did a healthcare policy fellowship in 2004-05 and came and worked and learned about the US healthcare system. Getting other people to come and work with you and tell you about their system and look at your system is an extremely important way to actually reflect on your own system. And we're lucky through the actual existence of the database to have worked with about 550 or more external co-authors on various publications. And I'd encourage any of you to capture me during the conference if you have ideas that we could explore together. And one of these, just with the Brazilians, they also have an ICU database just recently, is trying to tackle this notion that a sepsis population is not a homogeneous population. And what we've kind of done is harmonize the two databases and realize that actually the site of infection for patients with sepsis actually differs across countries, Brazil and UK. We've shown by virtue of later presentation, not only to healthcare, to hospital, and to intensive care, that actually patients in Brazil are more likely to have a greater number and a different type of organ dysfunctions. And that leads to an underlying difference in the mortality rate. So starting to actually tease out phenotypically, actually, that our sepsis populations are not the same when we go from country to country, and better informing perhaps how we do our research and do our studies in future. I told you about that NHS number, so the availability, the newly introduced NHS number, the unique identifier, which has now sort of populated our database, has allowed us to start looking at longer-term survival from critical care. So this is taking our critical care survivors and following them up to 5 years post-hospital discharge. I've just put the comparison here as an age, sex, and matched general population. So you can see the decrement, and you can see that the line is still sort of falling away for critical care survivors in terms of mortality over time. And we're now beginning to build risk models so that we'll be able to not only provide risk-adjusted hospital mortality for units, but also their risk-adjusted longer-term survival. So trying to actually see not only do we get them out of hospital, but are we actually providing ongoing sustained survival for these patients. The other thing that an ICU database allows you to do is it's a network of data collecting units. And this is our latest trial, the 65 trial that's sort of led by Paul Mountsley in the UK and Francois Lamontagne in Canada. And what I really wanted to show you this for was having this network of data collecting ICUs. This is 65 intensive care units collecting for this trial, participating in this trial. It allowed us to start early, and it allowed us to achieve a sample size. We're about 70 short of the 2,800. And you can see our pre-trial estimate of the recruitment rate to this trial was a pessimistic, or should I say a historic sort of prediction. And I think this sort of notion of data-enabling randomized controlled trials will lead us to getting our answers much more quickly, so establishing what quality care looks like. We've also provided 14 sites to, this is the first ever sort of cluster crossover ICU database or registry trial. This is Paul Young in New Zealand's trial, the PEPTIC trial, comparing proton pump inhibitors with histamine 2 receptor blockers for ulcer prophylaxis. And it quite simply, you randomize the centers to either use proton pump inhibitors for 6 months and then switch to the histamine 2 receptor blockers, or vice versa. And this trial has just finished, I was going to say data collection, but it's sort of randomization. The data will come from the database. And I hope the results will be out next year. The other thing that's very close to my heart is it's very difficult to get a handle on, if you think of the elements of quality as being the effectiveness of care and also the equity of care, is everybody getting it at the same and the right time and having equal access, is this notion of the humanity of care. It's very important to me that care is delivered with respect and dignity. Having had experiences, I'm not a critical care professional like yourselves, but having had experience of being a family member of someone in critical care. And more recently, we've used our sort of network of ICUs to actually start to work out how we might go about, if you like, introducing a quality improvement program looking at family satisfaction with ICU services. And we used Darren Hyland's family satisfaction with ICU services questionnaire. And we chose 20, we deliberately selected a representative sample of 20 intensive care units, geographically represented, split equally between teaching and non-teaching hospitals, big ones and little ones. And probably one of the first sort of things that struck me was obviously a lower score here is less satisfied, is that 4 of the units of the 20 were providing significantly poorer in terms of family satisfaction with care than, which is a large proportion of the 20 representative units. And then I think, again, something that sort of struck me from the results of this study, if you look along the x-axis there, you can see for overall care that the family members of non-survivors are actually more satisfied than the family members of survivors. And if we're getting more survivors and we're meant to be enhancing survivorship, it would seem to me that we've got some work to do on making the family members of survivors as satisfied, if that makes sense. And when you actually look across the domains of the questionnaire, it doesn't seem to be about the satisfaction with the care delivered in the unit. It seems to be very much about the information and particularly the decision-making that family members of survivors don't feel they're as involved in the decision-making. So to conclude, national clinical audit, those questions. Can we know if the performance of critical care in a nation-region network is good and if it's getting better or worse over time? I'd say yes, we can. Can we get a meaningful and reasonably understandable set of national quality indicators? Can they be identified? Can they be accepted by key constituencies? We co-design them together with all the constituencies. And can they be tracked? And can they form part of evidence-based policy discussions and decisions? I would say, yes, they can. So, to conclude, I would say that national clinical audit has a role to play, but for those of you who are doing very important work with guidelines, with protocols, with local quality improvement projects, I would argue that only one piece, the national clinical audit, is only one piece in the quality jigsaw puzzle. Without doubt, it requires buy-in and engagement at every level. So we have engagement from NHS England all the way down to the patients, the staff, the families of our critical care units. I think it's very key that the same amount of scientific rigor is put in clinical audit as we'd put into our research in terms of data, methods, our outputs, and it's important both to the perceived and the actual value of national clinical audit. There is a dearth of valid quality indicators, and I can feel the weight on my back to try and change that situation. But I think it's important to get on and do these things and not let perfection be the enemy of the good. And then finally, I think, as an activity per se, I think there's enormous added value to be gained from a high-quality clinical database in critical care. And I think that combined, I hope, leads to something that is useful and informative and influential in improving critical care and outcomes. Thank you.